Hello friends, now today we'll be discussing about the PK/PD parameters of antibiotics. Usually, initially, the antibiotics dosing and frequency of interval to give antibiotic frequency was determined by pharmacokinetics PK parameters only. But recently, in recent years, has been lot of investigation, lot of publication, and lot of advantage has been found after understanding the both PK and PD, that is pharmacokinetics and pharmacodynamics of antibiotics. After using this both parameter, it will help us to diagnose the dose as well as diagnose the frequency of giving antibiotics. These two parameters and its application has lot of advantage, has now processed for dosing and frequency interval. That is very important. And after using these two parameters, when we determine the dose and frequency of interval, then there is a lot of improvement, lot of clinical output is there. We have found that using both these diameter, there was a lot of clinical improvement has been found in our clinical trials. Even there was some advantage with fighting with this MDR pathogen. When we are using the correct dose and at correct timing with the correct frequency, then obviously there will be a good outcome from the patient point of view. The rate of clinical and microbiological cure of organism is better after understanding this both parameter and application with the dosing and frequency interval. So we'll try to understand it little elaborate. As I explained you that PK is pharmacokinetics, that means what a body does to the drug. Means if you take a drug, then it goes it enters inside your body. If you are taking orally, then goes into the stomach. There will be a dissolution, disintegration, then absorption. So pharmacokinetics K, there's actually 1, 2, 3, 4. I remember that is absorption, then distribution, biotransformation, and excretion. So it get absorbed, then it will be distributed, it will undergo metabolism, then finally excretion. That is the part of the pharmacokinetics. It is the body what does to the drug. But pharmacodynamics is the action of the drug that what it does to the body. Okay, so it will be after drug get absorbed, it reaches to the proper site and bind to the receptor, and after binding with the receptor, the effect it produces to the body is pharmacodynamics. Okay, so applying these two parameters, we have found that there are three types of bacterial killing. One is concentration dependent kinetics. We have found that when we increase the concentration of the antibiotic, the bacterial killing has been increased. The more the concentration of antibiotic, more is the bacterial killing. It is known as the Cmax over MIC. Okay. Then there is another group of antibiotics which we found that while we increase the time, it is called time memo of the MIC. When we give the drug and whatever concentration we give, how much high, it doesn't increase the killing rate. Rather, killing rate is more increased when its concentration was achieved above MIC. Let me tell you, when you give a drug, the drug enters inside, then it reaches to the peak, and then it finally goes down to its normal level. So when a drug enters into the body and it has to achieve by MIC. MIC, I have told initially that minimum inhibitory concentration that is in the blood, that will help to kill the organism. But our always target will be to achieve the MIC 4 times above the MIC. This is the usual normal rate of killing of organism. So when you are talking about MIC, it is minimum inhibitory concentration. So this is the maximum concentration will achieve and after maximum concentration, it according to the half-life of the drug, it will disintegrate down and goes to the below MIC and normal level. So this is Cmax, then this is MIC, and the area under the curve is also important. Okay, so what we are saying that if we increase the concentration of the antibiotic according to this group of antibiotic will kill the organism, more we increase the concentration. Okay, AUC by MIC means that area under curve, the amount of antibiotic that was being exposed to the certain organism over 24 hours, that is area under curve, and by MIC. So what we have came to know, there are the three. If we don't want to go in details, just to be a gardener you don't need to be a botanist. Okay, so if you are not going in details and trying to understand the basic concept of PK/PD parameter of antibiotics, means there are three classes of antibiotics according to the PK and PD parameters, and in which three types of killing of the bacteria can be done. Number one is you increase the concentration dependent kinetics, means you increase the concentration of drug. The more concentration of drug present in your blood, the more is the killing effect seen. This is called Cmax by MIC. Okay, then another is time above the MIC. Time above the MIC is the more the time you keep your antibiotic drug concentration above the MIC, more is the killing. In this group, whatever the concentration will you increase, that will not enhance the killing of the bacteria. Rather, it should be a more time than the MIC. It is said that if it is time of the MIC group of drug, and if you are not giving above 50%, suppose there are 24 hours, if you are not giving at least 12 hours of your drug which is above the MIC, if it is not achieving that concentration, means there is a 32% mortality. 30 to 50% mortality has been seen in the clinical trials. And if you are achieving this time of the MIC, that above this MIC, if you are achieving the maximum time, and we'll tell you in details, then there is the around 50%, 33 to 74% more increase in this outcome, clinical outcome. So you should always remember which class of antibiotic you are using, what is its the PK/PD kinetics, and according to that you can use the dose and you can use the frequency interval. That is the main point of this understanding of this PK/PD parameter of antibiotics. Okay, so let me go in details of describing this three class of antibiotic. If you describe the Cmax of MIC, as I have already told you, the Cmax is concentration dependent kinetics. It's the how much you increase the concentration, more is the killing effect. And the antibiotics that include in this group are aminoglycoside, daptomycin, amphotericin B, and nystatin. So what does this mean? What does the clinical application means of Cmax over MIC? It means that the higher the dose you will give the drug, the higher will be the killing effect. That is clear to you. But you should also be remember that how much is the higher. Every drug has its own limitation. If you goes to the more, the higher the concentration, there is the more chance of toxicity to the body. So suppose aminoglycoside, if you are using amikacin can be given the maximum dose, you can give 750 OD, this is a normal dose. You can reach to 1 gram. But once you reach to 1 gram OD, then there is increased chance of nephrotoxicity. So you have to always check and balance that how much dose is suitable for the patient, and at that dose, does it is causing any toxicity to the patient or not. That should you monitor and follow meticulously. Okay, so you have understood that if you are giving amikacin, you use higher dose. If you are using daptomycin, you will give higher dose, that is 6 milligram to 10 milligram per kg body weight. That will be the for daptomycin. Amphotericin B, you can use 5 to 10 milligram. You can normally we give 5 milligram per kg body weight, but even if you are thinking that 10 milligram per kg body weight can be given or achieved. The important concept is that Cmax over MIC, you should never go to the lower doses or increased frequency of doses. You have to keep this drug concentration higher. Once daily dose is usually preferred. Okay, that will be safety profile. But suppose if a person is going, if a patient is coming to you and he or she is going to have the renal impairment, now you need to modify the drug. What will you do in that condition? In that condition, will you reduce the dose or will you maintain the same dose but frequency will be more, wide gap will be maintained? As it is follows the PK/PD parameter of Cmax over MIC, so you have to be sure, you have to make sure that you are giving a high dose of antibiotic. So amikacin, if you are giving, it will be 750 mg in 100 ml NS over 30 minutes you are giving, and after that, if it is finding that okay there is a nephrotoxicity and you need to monitor the dose, then you give, not reduce the dose but give in 48 hours. That will be preferred. That will be more useful. Okay. If you are using daptomycin, suppose daptomycin you are used at 6 mg per kg body weight. Now when you are having a patient with renal impairment, then you are still saying okay I will need to reduce the dose for according to the renal adjustment. You are actually, you will not reduce the dose, you will make it the wide gap. Suppose daptomycin, if it is 30 ml per, creatine clearance is 30 ml per minute, then we usually don't reduce the dose. But if it is less than 30, then we'll give daptomycin 6 mg per kg body weight in, today we'll give, and after 48 hours. Usually dose is 6 mg per kg daily, but now for renal adjustment you will give in 48 hours. That is main concept of this Cmax over MIC. Okay. Now when you go to the timing of the MIC, timing of the MIC means you have to make your concentration of drug above your MIC for maximum period of time. What will be the time? This group of antibiotic includes the beta-lactam, mainly the all beta-lactam antibiotic, and beta-lactam antibiotics include penicillin, cephalosporin, carbapenem, and moribactam. So all these beta-lactams comes into the group of timing of the MIC. So what you will do, you will going to use this antibiotic, and it should be used in such a manner that your drug concentration above the MIC should be maintained for maximum period of time, mainly in the critical ill patient. So suppose if you are giving cephalosporin, then it should at least achieve 60 to 70% of your dosing interval. Suppose if you are giving any penicillin, then you need to give 50% of your dosing interval, and carbapenem then 40% of the dosing interval. What does it mean that? Suppose I am coming with the carbapenem. Let's begin with carbapenem. Okay, carbapenem 40% of the dosing interval. If you are using meropenem 1 gram TDS is used, or for normal adult, or if you are going to use imipenem, then we usually use 500 mg QID 4 times a day. So for imipenem it's and meropenem. Imipenem is 6 hourly, meropenem is 8 hourly. So between two doses there are 4 doses. Between two doses there is a gap of 6 hours. So if you are giving carbapenem, then 40% of the 6 hours should be, the dose should be there, antibiotics should be there in the blood above the MIC. That it means. Okay, so 40% of 6 hours, so you can say more than 2 hours. More than 2 hours. Okay, so more than 2 hours you have to give this imipenem. You have to achieve the concentration of this imipenem in your blood. That is of concept of timing of MIC. And if you are achieving more than 2 hours, or if we say meropenem is 8 hours, then 40% of 8 hours is almost say 3. So 3 hours this meropenem should be above the MIC to achieve the better clinical and microbiological outcome, clinical and microbiological cure of this patient. So what you will do, you will give this imipenem or meropenem over the infuser. Imipenem we usually give infusion over 2 hours. Meropenem we give infusion over 3 hours. Okay, if we are going to use doripenem, then that can be given infusion over 4 hours. If you are going to use piperacillin tazobactam, then what should happen? You are using 4.5 gram TDS. Okay, but when you are going to give it over infusion over 4 hours, 50% of time. If it TDS 8 hour, 50% is. Let me explain about for the piperacillin tazobactam. That is will be important. Piperacillin plus tazobactam. So its dose is usually 4.5 gram TDS, normal dose. Okay, so 8 hour interval is the gap. If penicillin 50%, so 4 hour there should be this piperacillin tazobactam should be above the MIC. For this 4 hour, what we will do? You give this piperacillin tazobactam for over 4 hours infusion. During infusion, there will be the what happens when you are giving infusion, then there will be this like curve. So maximum period of time of your antibiotics is above the MIC. That means, and after this, there was actually a lot of clinical and microbiological improvement. There was a lot of clinical outcome. That is very important. Okay, so whenever you are going to use beta-lactam antibiotics, then try to use it over infusion, if especially to the patient who are critically ill. Okay, and when you are going to fight with the MDR pathogens, these two conditions you have to use this over infusion. The infusion rate of, if you are going to use what I am saying here, imipenem is 2 hours, meropenem 4 hours, doripenem, no, it's 3 hours, doripenem 4 hours. Okay, if you are going to use piperacillin tazobactam, 4 hours. And there has been found that there is a lot of clinical improvement. I am saying repeatedly this point. Please, if you are using any beta-lactam antibiotics, then infusion to maintain the time of MIC is very, very important. Okay. Now that comes to the AUC by MIC. AUC by MIC is area under curve. So it is total 24 hours. In 24 hours, how much antibiotic has been exposed to that particular drug is important. Okay, so you have to know this group of antibiotics include fluoroquinolones, tetracycline, polymyxin, vancomycin, and fosfomycin. Okay, so there are few exceptions as well. Let me first clear about this concept. What does this group of antibiotic needs? It needs that the area under curve, and MIC is this, area under is this, and AUC, that is area under curve in 24 hours, how much antibiotic has been exposed to that particular drug, a particular antibiotic microorganism by MIC is the value that is required for better clinical and microbiological outcome. So when you talk about the AUC by MIC, the first number drug is fluoroquinolones. Okay, so fluoroquinolones, and what we this indicates that dosing and frequency interval. Cmax by MIC said there will be a single dose but high concentration. Time of the MIC says there should be frequent dosing, okay, and it should be achieved, the MIC should be, the drug concentration should achieve above the MIC. That is very important in this group of antibiotic. Well then, AUC by MIC indicates that we can give the drug, it is flexible, that is both concentration and time both is required for killing the organism, killing the bacteria, and for that we usually give fluoroquinolones, ciprofloxacin BD. If you are using tetracycline, we usually give doxycycline BD, polymyxin BD, even TDS can be given, vancomycin BD, fosfomycin we usually give 4 hourly, the 6 hourly, 4 times a day. Okay, so this is actually flexible, this is adjustable. Fosfomycin can be given one in TDS also, it can be given 4 times also. It's depend upon what you are using. If you are using 8 gram, it can give in TDS. If you are using 6 gram, it can be used as 4 times daily. That is depend upon, this is flexible group of antibiotic. You can use 2 times, 3 times, it depend upon how you are going to use. And those can be also be flexible. This group of antibiotic indicates this. Okay. There is an exception to this and this, okay, group of antibiotic. If fluoroquinolones normally follow AUC by MIC, but when it's in certain situation, it can follow the Cmax by MIC in some situation. Okay, if your aminoglycoside normally it is Cmax by MIC, but in some time they follow AUC by MIC. Let me give you an example. Suppose if you are going to use aminoglycoside, that is amikacin, for any pseudomonas infection in tuberculosis, everywhere you are using, you will be going to use 750 mg only. But when you are going to use gentamicin and topramycin for sepsis and pneumonia, you will use once daily dose, high concentration, once daily dose. Okay, that is really preferred. Normally we use gentamicin 3 to 5 milligram per kg TDS in case of endocarditis. I am coming there. But if you are going to use for sepsis or pneumonia, you can use 5 to 7 milligram per kg once daily dose. Okay, so that is follow the Cmax by MIC. But for certain situation like endocarditis, you are following this antibiotic according to the AUC by MIC, means you will give in frequent dose, that is adjustable dose, flexible. You can give 3 times daily. Suppose 3 to 5 milligram per kg gentamicin, it's given with adjuvant to ampicillin for enterococcal endocarditis. Okay, so that will be 3 milligram per kg per day and divided into 3 doses. So 1 milligram per kg per dose 8 hourly will be used for AUC by MIC. Okay, so if you are going to use this, let me clear you one more thing, that AUC by MIC, suppose AUC by MIC, AUC by MIC for suppose vancomycin, you take vancomycin Staph aureus, so it should be 400, greater than 400. Look, the area under curve by MIC, it's, if we are going to divide for vancomycin for Staph aureus, then for better killing it's required 400, above the 400. If you are going to achieve this 24-hour drug concentration above MIC is 400 times than that of the MIC, then only you will be having better clinical outcome, better killing of that Staph aureus. That is very much important. Okay, so let's end into this. We will be discussing in detail more about each antibiotic and its detail of one group in next video. That will be very helpful in a detail to understand. Let us make this lecture as an overview, and at least take home message from here is that whenever you are going to use this group of antibiotic, always single daily dose should be preferred. If you are going to use time over the MIC, there should be frequent dose interval, and if possible, you have to use maximum time over infusion, and the infusion rate should be imipenem 2 hour, meropenem 3 hour, doripenem 4 hour, piperacillin tazobactam 4 hour, and it is the fixed time because you have to also understand that imipenem is not stable more than 2 hours. So if you are giving imipenem over 3 or 4 hours, then that drug is totally waste. So that also you should keep in mind. Meropenem you cannot give more than 3 hours infusion; it will get damaged. Okay, so that time limit is also important, and if you are keeping in mind, then these things will certainly help you a lot in managing your patient, and you will see that the miracle does happen in infectious disease.